Hi everyone! Time flies and we are finishing the fifth day of conferences. So far it has been incredibly intense with so many great conferences from the best speakers in aesthetic dentistry worldwide. Now, I'm very happy to present a great master that will close it for today. From Brazil, someone who has worked so hard throughout his life to change and evolve dentistry worldwide, Master Paulo Cano. Paulo is not only a dentist, but is also a dental technician since 1974. Dr. Cano is a master in implantology from the Faculty of Dentistry São Leopoldo Mandic, where he is professor and head of the Department of Digital Dentistry. He is also the visiting professor of the postgraduate school of the University of Santa Catarina in Brazil and the visiting professor of the Department of Restorative Dentistry of the Brazilian Dental Association in Florianopolis. Dr. Paulo Cano is an emeritus member of the Brazilian Society of Aesthetic Dentistry and runs a private practice in São Paulo, Brazil since 1988. Paulo Cano has also published international and nationally in the areas of aesthetic dentistry, prosthetic, and dental laboratory. He is the author of the book Challenging Nature and the creator of the skin concept. I'm sure you will love his presentation. Tomorrow we'll start again at 8 a.m. GMT for the last day of the International Aesthetic Masters. Don't miss this last day.
Hello everyone, my name is Paulo Cano and I'm going to present to you a concept that integrates natural teeth morphology and the CAD/CAM technology to obtain the maximum precision, quality and speed in replicating the complexity of the tooth surface. Before this new technique, only a real technical artist could replicate the surface texture and luster of the natural teeth with such perfection, and also worry about occlusion at the same time. However, the skin concept, along with the CAD/CAM system, can recreate the teeth surface in the most natural way and convert into the restoration. There are several ways to create a dental restoration. The conventional dentistry needs preparation, impression, provisional, lab, wax-up, and it will take a multiple proof until you achieve a desired outcome to cement. The DSD plan uses the same line reference as we do in conventional dentistry to plan a patient's smile. The only difference is that these line references are done digitally in regular software such as Keynote, PowerPoint, or similar programs. However, you will still need the wax-up handmade process and several proofs to get a proper result. The 3D digital dentistry uses 3D digital technology, but the dental morphology database is not extracted from natural dentition. The lab technician manually sculpts each tooth, and it still takes multiple proofs to make the necessary adjustment before accomplishing an adequate result. The skin concept is different because it reduces many of these clinical and laboratory steps. In other words, there won't be a lot of back and forth between lab technician and dentist to create a personalized and natural smile for your patient. It also uses digital planning and 3D digital simulation, and it will give you a more precise surgical guide. Plus, it's the only method that allow an exactly outcome prediction in the beginning of treatment. So it will make an excellent sealing tool to help you increase your revenues. None of the other methods give you a true simulation of the outcome in the beginning of treatment. Only the skin concept can do this. The word skin did not have any real meaning in dentistry. The name skin concept came up because it is based on copy the tooth surface as tooth shell. This way, skin has now meaning in digital dentistry. In 2013, this technique was published on Quintessence as AST, Anatomical Shell Technique. I wrote this article with Jonathan Fanansky, Eric Van Duren, Nelson Silva, and Christian Xavier. In 2015, I've changed the name again, Skin with Y, because I had invited Livio Yoshinaga to help me to promote internationally this technique. But I've noticed that I hadn't become too commercial, trying to sell technology instead of the concept itself. Since I am a dentist and I'm worried about keep the skin concept in a more clinical and education level, I have decided to separate myself from Livio and return it to original name Skin in 2017. One of the challenges in aesthetic dentistry is achieving natural shape and like life surface textures. A restoration that does not exhibit surface texture and luster comparable to the adjacent natural teeth will immediately appear out of place. With the skin technique, both dentist and technician can mimic dental morphology in a way that is indistinguishable from adjacent natural teeth. This is possible because there is not need to create the tooth morphology. Technology has already replicated it from natural dentition in a much more precise way than the human hand can do it. The only things you have to remember is that technology does not create shape or art. It replicates it. And this replication gets closer and closer to perfection by each improvement in technology. There are a few ways to mimic dental morphology. One of them is the handmade process, which requires a highly skilled laboratory technician who will use wax up or ceramic procedure to replicate the natural dentition. The other two ways use digital technology, and we will tell you more about them in a few minutes. There are infinity shape variation, different combination that can be replicated. Each one of them has its own mathematics and algorithm. For an artist to learn one algorithm, he will need to practice it by repeating the same algorithm several times. The more he practices, uh, the more he learns. But what he learning? He's learning more of the same things. He learning only one variation, one combination, one algorithm. That is why the artist will usually use the same algorithm for each smile he designs. And all patient smiles will practically look the same. Regarding the wax-art procedure, there is at least 6 month basic learning curve period, while for gaining aesthetic skill, he requires approximately 6 years. Actually, this point happens simultaneously, but I really believe they obtain satisfactory knowledge on a 10 years. When are taken 10 years? When are taking about ceramic procedures, the basic learning curve takes at least 6 years, but to gain 6 years, but to gain 10 years. It takes a very long time for lab technicians to become proficient, and not at all then will turn out to be real artists. Plus, most artists have their own style, their signature. That means that a lot of their sculpture will basically look the same, all have the same smile. All have the same smile. Nowadays, there are only few world-known real artists who can mimic a tooth with perfection. Big name in dentistry use these artists to do it. However, their patient all end up with the same smile, and most dentists won't even have the opportunity to work with these artists. I'm going to show you 2 ways to can replicate the natural dentition without having to do it. 2 ways to can replicate the scratch. In this two workflow, both dentist and lab technician can achieve great result and a luster faster and the artist's handmade technique. Both methods extracted the natural morphology from real dentition to mimic dental surface. The difference is that the first one uses physical model and the second uses a digital database. I named it as chair-side smile design, the physical model workflow, because the dentist himself will create the most appropriate smile for his patient right from his own office, straight from the patient mouth. And I have named Outsources My Design, the digital morphology database workflow, because the lab technician is responsible for choosing the patient's smile. Since this workflow, the teeth morphology has already been determined from the start. The lab technician does not need to remake after the milling of the ceramics. When the morphology is not extracted from natural dentition, the technician needs to recreate the teeth anatomy, reshaping the original design. That is why the initial design usually does not look anything like the final restoration. In other words, the initial aesthetic is very different from the final one. Unfortunately, this is what normally happening in conventional dentistry and GCD planning. Even in 3D digital dentistry, that does not follow the workflow I am about to show you. And please don't confuse when using the physical model as well as when using the digital morphology database. Both processes are totally digital. From the moment the dentist scans the patient dentition and send the image to the lab until the technician will the final restoration. This entire flow is done completely digitally. But I am getting a little ahead of myself here. What you need to know now is that in dentistry, every clinical procedure is analog and it depends on operator ability and experience. The digital process starts the moment you use scanner, digital image, software, etc. In in this process, the aesthetic proposed is about the chairside smile design workflow. In this process, the aesthetic proposed is designed by the dentist using physical natural morphology model. About this physical model extracted from real dentition, its texture and anatomy can be replicated with a polyvinyl siloxane impression. After the setting of the silicone, you will apply a thin layer of flowable composite resin and light cure it to manufacture composite veneer. Your assistant can help you make this composite veneer from different physical models, so you will have a varied selection of dental composition to choose from. You can combine different morphology to create unlimited type of smile. For example, you can choose a distinct form and a structure for a central incisor, lateral canine, etc. And your patient can also show you which style they like. So you, dentists, have the capability of choosing the best smile for your patient without depending on a laboratory technician. And your patient will have personalized natural aesthetic opposed to what is created by the lab technician artist who has his own signature. The best part is that this veneer can be applied directly into the patient's mouth. You will be able to design and demonstrate the patient outcome smile in their first visit, giving them a reliable and precise outcome prediction from the start. This will motivate them to accept treatment and will help you building a more dependable professional relationship with them, since the mock-up and the final outcome look exactly the same. The patient feels a lot more confident when the dentist himself can show them his own smile design capability. You can apply this veneer and replace them very fast with different morphology according to your judgment and your patient choosing. You can also adjust their position very easily, so you won't need to receive several proofs from your lab to building a perfect natural smile. With a WhatsApp mockup, you cannot adjust their position or replace them with a different proportion or and natural and morphology because they are inflexible. Instead, with this composite veneer, you have the flexibility to reposition them to change their size and morphology according to what you feel in the best results for your patient. You can create an aesthetic proposal in less than 1 hour because you don't need to take any photos, record any videos, make any plastic model, nor WhatsApp. That is, you don't have to spend a lot of money in photos, video, plastic model, and WhatsApp before patient accept treatment. This proposal is this proposal is what you call motivation mockup because you can impress your patient by changing their smile immediately, showing them personalized aesthetic results. And this point have you have not invested a lot of money to do all this. You can analyze whether or not. Now the dentist become the artist, which is the opposite of the conventional dentistry proposition. Before, only the lab technician had capacity to design the patient's aesthetics. The dentist did not have it. I'm going to show some example of how people all over the world can apply the chair-side smile design workflow. This is one case of motivational mockup made by one of the students, Dr. Ilya from Russia. One of the bottom left picture, you can see the patient original gum smile. He has applied veneer in her mouth and changed completely her appearance. See another example of the before and after the application of motivation mockup. The patient had upper lip problem. It looked very small, which gave her insufficient lip support. With the chair-side smile design workflow, we had the veneer ready to be placed directly into the patient's mouth and were able to evaluate how much we needed for lip support to create a change her smile. This patient had an upper lip problem. It looked very small, which gave her insufficient lip support. With the chair-side smile design workflow, we had the veneer ready to be placed directly into the patient's mouth and were able to evaluate how much we needed for lip support to create a change in her smile. On the before video, you can notice that she is hiding her upper teeth and gum. She's only showing her lower teeth, which means that she created an inadequate facial muscle tonus. After applying the veneer, she starts showing not only her teeth length, but also her gingiva. Please also notice that her upper and lower lip stick to each other because her lip that is closer to her oral commissures does not have lip support. This happens because her upper lip is always in the lower lip wet mucosal zone. The correct ways is having the upper lip outward, then the lower lip in dry zone. The second video was made 2 hours later. This was a more complex case because she has asked us to change the teeth length. You can do it by removing the veneer and reapplying them in a different position. It took only two hours to do it. This WhatsApp, if this WhatsApp handmade veneer, you would have not been able to make this change right away. You would have had to waiting for the lab to do this a new WhatsApp, and she would have had to come back to your office to try it on. On the after video, you can see that her lips and her papilla had changed radically, and the videos show it all. Each case has its own complexity. With this patient, we have not only analyzed her area. Some line references are essential to create more harmonious face. By applying the nose wing vertical line reference, you can examine her canine position. Since they are not correctly aligned with her nose wings, she lacks a supportive lip, which makes her look older. There was a bigger discrepancies of the canine position on the right side than the left one, giving a more symmetric upper lip support. See the before and after photos as they show very different smiles. On the left side, you can observe a more convex lips, and after applying the motivation mockup, you see a straight lip. Both upper and lower lips have been filled out, which change her was the veneer that we will have applied in her mouth respected the emergence profile. Before you could not see a more asymmetric face, and now is more harmonious. And when the patient used more the upper lip to smile, she looked younger. It has transformed her appearance. Unfortunately, the size proportion cannot be completely correct in this case because the veneer placement is limited by the emergency profile. However, it is possible to change the axial position by making the buccal inclination of the incisor edge. You can adjust all the teeth position during the mock-up step. Whenever you feel comfortable with the results, you can scan the simulation and send it into the CAD/CAM system. The simulation is identical with the final outcome, giving your patient an extremely reliable prediction. The patient participates in the process of building her a new smile. This gave her more confidence that she would be happy with the outcome, especially because the mock-up is identical with the final result. Another example, this patient also had a gun smile. Her teeth were disproportional in size, especially the right pointy canine. With the motivation mock-up, you can simulate the outcome prior to beginning treatment and also understand your limitation. It makes you comprehend what can really be achieved. You can see the result on these photos. Please notice the right canine and how we have positioned the veneer to give her a more proportional side dentition. Her smile is no longer gummy either. In this photo, you can compare the right and left sides on her face. You can really see the change, especially on her right canine. There are many reasons why the dentist should work with the composite veneers. The first one, that there's nothing better than to also give the dentist the capacity to creating and evaluating the final smile. Second, they give you a much better idea of the case limitation as they show you the real outcome. Third, they are easy to make and low cost. The fourth, they can be used as surgical guide because it show you the exactly surgical line. You just following the proper contour of the composite veneer to give you the proper amount on gun and bone that you will need to cut out. The fifth, after the surgery, you can apply them again to check if there will be a perfect fit of the restoration and cementation. Some dentists even use them to help prep the dentition, as the veneers may assist them to figure out how much they need to prep each tooth. As I have mentioned before, the motivation mockup is also used as a surgical guide. We always need to have a full aesthetic purpose and be sure it because the gingivectomy is an invasive procedure. In the chairside smile design workflow, periodontal plastic surgery becomes easier. You are able to perform a gingivectomy with more precision and how it is usually done. Let me explain to you why. You have your patient initial scenario. You create the motivation mockup and show the precise outcome prediction to your patient. Then you can use the guideline because it is contour will give you this exactly surgical line. This way, you have drawn a line where you should cut the gingival and the bone. You won't cut more than what is necessary. You can apply a motivation mockup back into the patient month after the surgery. You make any need adjustment for the final smile. This crown length procedure is simple. However, there are some limitations and you must learn this technique before performing an adequate gingivectomy. There are two videos to illustrate how the procedure is done. The first one shows us how we use the motivation mockup as a guideline to determine aesthetic contour. After the incision, the tissue is removed using scalpel, and thus we already have a dental lens according to plan. Sometimes we need to do an osteotomy as well. Since we have already removed the tissue, we know how much of the bone we will cut out. The second video displays how we can do it by using an piezo ultrasonic technique. These two burrs were magnified in 300 micromet. The right bottom picture shows the conventional burr. To manufacture it, they use the electrolytic process to diamond crystal particle on its tip. This product can cut any hard, strong materials such as the human bone. However, you can outline the cut very well, so you may damage your patient's teeth while trying to cut only the bone. It can also scratch the teeth root and surface. The second burr on the left top photos is manufactured by using chemical vapor deposition process based on very high temperature and pressure using different gases. The diamond draw on the surface the molybdenum metal, creating flatter and more rounded diamond crystal. So it will cut the bone easily but without damaging the teeth. In order to do this, the operator needs to continuously move the burrs. Here we will show you a video of an osteotomy using the TR1PK CV dentist burr and how it is fast and easy to perform this surgery. After surgery, we position again the composite veneer to make any new adjustment to create the final smile design. The first step after creating the final smile design is to scan the aesthetic repose with the composite veneer in place. Once we are done with it, we will prepare the teeth and scan it again. That is what we call double scanning tooth. Using the double scanning tool, the software does the correlation of the external surface of the veneer with the external surface of the preparation. As a result, it combines the external surface of the veneer with the external surface of the preparation. So the lab technician can define the cervical margin and give a better finishing of ceramic veneers. Let's show the chairside smile design entire flow chart so you can get a better understanding of the whole process, especially the laboratory workflow. It's good. So far I have described the analog treatment process done by the dentist and at the end when we prepare the teeth. Then we double scan the prepared teeth and the final smile design to virtually send both files to the lab. The lab technician, who is now different professional because he needed to learn the digital process himself, will adjust the combined image to the 3D printed model. At the same time, they mill the ceramics to create the restoration. Once they are done, he will place the restorations on the print model to check their fitting. And at this point, he will start the finishing process and polishing, staining, and glazing the veneer before sending them to the dentist. If the dentist does not have a scanner to digitalize the image of the prepared teeth and the final smile design, he will make the conventional impression to send them to the lab. The lab will need to have a scan to create both digital image. After that, the process is the same I have previously described. 3D printed the model and mill the ceramics. With this technique, the final restoration is the same as the chairside smile design proposed created by the dentist. You can see it through these photos. The first picture on the left is the chairside smile design proposed. The other one are the final restoration. There is exactly the same. Why? Because the technology makes a perfect copy of the intended object. Therefore, it is very important to have a good proposal to obtain a positive and predictable results. Using a replication of natural dentition made by a copying of silicone or biotechnology, I can create variety of smile types. This is amazing because we can use a central incisor from a model, lateral from another model, and canine from a completely different model. And we are able to combine them according to what we need. The algorithm of natural dentition is infinite. I never create the same smile. All cases are different, and you can notice is here through these photos. I can personalize each smile. When a dentist works with only one lab technician, we will end up with equal smile all his patients. If we will look closely to the patient's restoration, we will be able to note some difference in each tooth anatomy, and these imperfections are the reason the smile looks so natural. This is what make a perfection imperfection, because that is how nature is. Let's talk about the second way you can replicate a natural dentition without having to do it by hand or from scratch. This workflow is called outsourced smile design because I had previously mentioned the lab technician is responsible for designing the patient smile. The design is done outsourced. Instead of using physical natural morphology model as we need do it in chairside smile design, here we use a digital natural morphology database. So you don't have to make the composite veneer as the patient static smile design is done in the lab. Because of it, you will need to send the laboratory enough information of your patient. All you have to do is to gather this information. Let's show you a floor chat to better illustrate what I am talking about. So, what information are going to send to your lab? First, an intraoral scan of your patient mouth. The second, a frontal facial photos. Third, intraoral photos. Fourth, a videos. Fifth, you can also add DSCD planning, but it's not necessary. The software used to create the patient smile also has the most important reference line, and the lab technician can apply them and her face to better analyze her case. The sixth, face scan has not been used yet because nowadays there is not a software to integrate with digital dentistry. It will be possible to use in near future, but with the technology we already have now, we can accomplish what we need. So you will need to take frontal facial photo and scan the patient intraoral, so the lab is designed can take the 3D image from the scanned file and place into your patient's 2D frontal facial photos. From the 2D image, he will know where her reference line are. For example, the dental midline to correct align the 3D scan file with her face. He will also be able appropriately position the new digital teeth morphology over the combined 2D and 3D and play the video that show this process later on. Right now, you just need to understand that it is important to have both initial intraoral scan and frontal facial photos. When software is developed to allow us to integrate face scan with digital dentistry, we will be able to shorten the amount of information we send to the lab. Because the face scan is a 3D file, we won't need to do 2D frontal facial photos. There already are software that use face scan with the capacity of showing facial expression, such how the person smiles, so the video won't be necessary either. The intraoral photo are used to deepen the analysis. For example, when the patient has a turnaround tooth, by using the intraoral photos, the technician will be able to get more detail of this tooth and its adjacent teeth. Since photos are static, a video will also help us see different and important detail in the patient's smile, such as whether or not she hides or. Let's start showing you and taking how her lip move, etc. Let's show how to properly scan. Take a photo and make a video so the lab technician can do a good job in designing your patient's smile. Let's start showing you how we do the initial intraoral scan. I need to ask you to apologize for me the demonstration it with a patient who had already had her teeth preparation prior to scan. I did not have video then displayed a true initial intraoral scan. This was the only one I had to add in my presentation, but it is exactly the way you scan it. So applying your patient decision yet, you are going to scan it so your lab technician can design a new smile knowing where the position is restoration. In the right hand side video, you will notice how important you have your computer near your while you need to do scan, because it is where you will be able to know when you have a correct scan her entire dentition without leaving any unfilled area out. You will need your assistants help you to make sure the teeth are dry while scanning them. She can also help you and pulling the patient cheeks always, so you can place the scanner in the correct position to better scan upper and lower teeth and restoration by your patient. You will need to scan all the three images. A frontal photo is also very important. There are some details you need to pay attention prior to taking your patient picture. Make sure it is a frontal face image of your patient's smile. The ears width are the same in both sides. The corner of eyes are aligned to your face contour. And her smile cannot hide either the cervical margin nor the incisal edge. Therefore, the left-hand side photo is not the most appropriate to send to the lab. The right photo hides her cervical margin, and the right-hand side photo does not show her incisal edge. I don't recommend to use the lip retractor to make the patient frontal facial photo either. By using the retractor, I does not allow you to see her lip shape, which helps the technician to analyze her face while designing her smile. When it comes to intraoral photos, it is important to send the lab frontal, lateral, occlusion, 12 o'clock photos. The more photos you send, the better capacity the technician will have to analyze the case. As I have previously mentioned, video is important to give you a real idea or how your patient smile. In this case, she did not show her gum smile on the photos. You smile on the photos. You clearly not it by watching her video. When you have the photos, video scan, GSD plan ready, you send them all to your lab by email or any other transfer file way you may choose. When the lab technician will start creating your patient's smile, he will use a 3D scanned intraoral image to virtually place new digital dental morphology over the patient teeth. If you compare this process with the chairside smile design workflow, you will notice that the digital dental morphology here substituted composite veneer directly into the patient's mouth. You choose the best morphology to each tooth, even from a different model, and position the veneers according to the desired outcome. Here you on the outsourced instead of same thing but digitally. Instead of having a live patient, he has her image. Welcome. Instead of having a live patient, he has her image, and instead of the physical composite veneer, he has a virtual library of natural teeth to choose from. This library is also extracted from natural dentition. Same a physical model. The only difference is that the other is digital. The technician can also choose a distinct form and structure for a central incisor, lateral canine, etc., just as we do on the chairside smile design workflow. The dentist and lab technician will take to each other during this phase to make all the needed adjustment on morphology and positioning of this teeth. This talking we can done by video call using Skype or similar application, because the tech can show all the work to the dentist through the computer. In this video, we see how we use the 3D scan file and how the tech position the new digital morphology over the patient natural dentition. Then He placed the 3D scan file with the new morphology into the 2D frontal-facial photos. It is at this moment that the tech will be able to check the facial reference line and the patient's curvature and emergency profile to adjust the restorations, position, and create the final virtual smile design. Once the dentist and the technician are satisfied with the 3D virtual smile design, the tech print is a physical model to send it to the dentist. If the dentist has his own 3D printer, he can receive the 3D virtual smile design file and print it himself. Now, the only things that the dentist need to make is a silicone index based on the 3D printer model. He will direct place into the patient's mouth, and thus this will have the first mockup to have the first smile outcome simulation. This video shows the lab technician designed the patient's smile. He applied the virtual veneer he got from the Library of Natural Teeth Morphology over her intraoral scan. Please notice that we change its transparency so we can compare her new smile design to her initial dentition. After applying the 3D intraoral scanning into the 2D facial image, the technician will adjust the restoration position according to her reference line, dental curvature, emergence profile, etc. Once the final smile design is ready, the technician print the 3D model and send into the dentist. On the left-hand side photos, you see the 3D print model that the laboratory sent to the dentist. He marks the cervical line with a pencil on the model. He mixes the silicone with the catalyst for the impression and apply the mixture over the model. When he does it, the cervical line mark will be transferred to the index and he will know exactly where to cut it. The second column, you see the silicone index that the dentist has made and him applying the bisacryl resin in the index. On the third column, the top photos show the dentist placing the silicone index into the patient's mouth. It takes about 5 minutes for the resin to polymerize. Approximately 1 minute after placing the silicone index into the mouth, the dentist has to clean all the bisacryl resin excess. He needed to follow the index contour to do this. And this must happen while the resin is still polymerizing, never after it has already polymerized. That is why it is usually done about 1 minute after placing the index into the patient's mouth. Once the bisacryl resin has polymerized and the dentist has pulled the index out of the patient's mouth, he will have the first mock-up. You can see the mock-up on the third column bottom photos. At this moment, the dentist takes a patient's photo and observe her while he smiles and talks to analyze whether or not the mock-up is the final desired outcome. If so, the patient will be ready for surgery and preparation. The dentist will use the mockup as a surgical guide, the same way I have explained to you on the chairside smile design workflow. If not, the lab will make the needed adjustment and send the dentist a new 3D printer model. The dentist does the surgical crown lengthening procedure using the mock-up as a guideline. In this case, her gingiva was too thick. I could not leave her with this much tissue volume. I have applied a laser peeling to smooth her gingiva. The dentist does not the osteotomy and preparation of the teeth in the same way I have demonstrated when I explain the chairside smile design workflow. The dentist can also use the mock-up as a guide to prepare the teeth. Once the teeth are prepared, the dentist will scan the prepared dentition to send this file to the lab. There is one difference between the chairside smile design and the outsourced smile design workflow. On the first one, the dentist used the double scan tools to send both prepared teeth and final smile design file to the lab. Here, in the outsourced smile design workflow, the dentist only need to scan the prepared teeth and send only this file to the lab. Why? Because the lab technician already has defined smile design file since he was the one who created. It is the same file he has used 3D print model. Since the lab technician has both files, the procedure is the same as on the chairside smile design workflow. The software does the correlation of the external surface of this veneer with the external surface of the preparation. As a result is combine the external surface of the veneer with the internal surface of the preparation, so the lab technician can create the final design. He will 3D print the model, the same way that he doesn't want the chairside smile design workflow. Formlabs 2 is the 3D printer for this model. The lab technician will mill the ceramics at the same time as he 3D printed the final model. In this case, the patient he asked us to add a little bit of color on her canines. Rafael Ferro was the one who made the color adjustment. After finishing process, we can end the workflow by cement the veneer in patient's mouth. The following photos show you the final result. Her teeth are monolithic veneer, but have a strong and natural color, and the lab tech is able to do this type of finishing. The patient also participated in the process of building her new smile. This gave her more confidence that she would be happy with these results. I'm going to show you another example. The before photo on left hand side show you how the patient's upper lip was prior to treatment, a bit convex, and how she did not show her upper teeth very much. On the after picture, she has a straight lip and show more her upper lip, even making her nose a bit more upturned. This was also possible because we gave her more lip support, correcting her facial tonus. She had vestibularized the central incisors. Also had diastema of central incisor, lateral, and canines. Actually, her teeth were too disproportional. This is a person who clenches her teeth a lot, mainly because of stress, and had several worm dentition. Therefore, her biggest issue was her lack of vertical dimension of occlusion. We had to increase it. On this side, I had applied photo-cured polymerized composite resin to define her new vertical dimension of occlusion. With this, we can scan the new video. On the left-hand side video, you see Emerson drawing a line of her initial 2D frontal facial photo of the area that will be associated with the 3D model. Then he associated the two images by correlating one dot on the 2D image with the one dot on the 3D scan, doing it tooth by tooth. He applied many dots on each tooth as needed to correctly correlate both images. After doing it, he chose the teeth morphology and placed in on the 3D intraoral scan image. This software has the reference line, midline, curvature line, etc. So he can use it then. Note how they change the inclination, rotation, and position of each tooth while designing her smile. I had told him to place this central incisor veneer a bit more toward the palatal. When he did it, it showed the position of the initial central incisor a bit more outward than the restoration position. So it gave us the idea of how much to wear the teeth out. We 3D printed the model and make the silicone index. The lab technician 3D prints both the initial teeth position and the proposed design, all in one model. Notice how the initial position is more outwardly inclined than design proposal. This model is an excellent guide for the teeth pre-preparation. This is a photo of a mock-up applied into the patient's mouth. It will be our guide to prepare her teeth. We will know where and how much to prepare the teeth out. This video show you the making of the first mocha done directly into the patient's mouth and how it guide through the teeth pre-preparation. In the end of the video, you see the crown lengthening surgery using laser technique. This is the photos of the prepared teeth and they are apart by retraction cord. Now you can scan it to send this 3D image to the lab. As I have previously mentioned, the lab technician combined the external surface of the veneer with the internal surface of the preparation, and now he is able to finish the design and print the veneers. Here we see the final restoration. Rafael Ferro, as technician, also did this case finishing process. Só mostrou o nome dele. Não mostra nada. Uhum. Her final smile. Another photos, lateral views. From here on, I will talk about how to use the outsourced workflow for full mouth digital rehabilitation. I'm going to show you a full mouth digital rehabilitation case that I have started in the beginning of May 2017 and was able to finish it in only 3 weeks. On June 2nd of this year, I presented this case in the International Symposium of Ceramica in San Diego in the USA. In the last 7 years, I have worked on several rehabilitation cases that we needed to increase the bite dimension using a combination of analog and digital step on the workflow. But only this year, with the 3Shape technology improvement, it was possible to do this entire job digitally in only one software. Let's start talking about this case. Initially, the patient had not demonstrated any TMJ symptoms. We took the initial photo the same way that we had previously discussed on the outsourced smile design workflow. We have also recorded a video so the technician was able to learn more detail about the patient. The third step of the workflow was to do the initial intraoral scanning and restoration bite. Again, the same way we do it on the outsourced smile design process. Now that technician has all the information, he needs to work on the case. With the 3D 3Shape software, he has the capacity of placing the upper and lower arch in a virtual articulator. With the initial intraoral scan, the technician knows the patient's regular occlusion, and with the virtual articulator, he can simulate all the mandibular movement in a virtual way. In this case, we know there is a lot of video loss. I have my own database of digital natural morphology that I have extracted from natural dentition. We use this library to build the patient full mouth rehabilitation. So my technician Emerson Lacerda placed the virtual veneers on the patient's 3D image, and then we can start planning the occlusion with the measurement we need for the vertical dimension occlusion. My personal preference for increased video is the musculatory reference and skeletal analysis, combining both of them to get the anatomical facial measurement. I won't explain them in detail right now because we don't have enough time. Just know that is how I prefer to measure the video. In this case, since the teeth were more vestibularized, we had to plan a new proposal with more vertical teeth position. This photo shows the technician applying virtual restoration on the 3D intraoral scanned image onto the 2D frontal facial photo to have a correct aesthetic alignment. Same way we did in the outsourced smile design workflow. In this photo, Emerson creates the 3D model so I could transfer the new proposal of the rehabilitation into the patient's mouth through the mockup. Notice how the initial position of the teeth is also more outwardly inclined that the design proposed, same as the last case. In this video, we see that the new rehabilitation proposed has been transferred into the patient's mouth, so we know which teeth need to be warm, prepared out, so we can pre-prepare each tooth. This mock-up will be used as a guide for surgery and preparation as well. In this STL file, you can visualize exactly the patient area that we need wearing out because they show you a geometric surface of the intended object. So you can notice that in this case, both upper and lower anterior jaw need. In this case, both on the posterior teeth, you can notice that the position of natural dentition is too palatal, and we need to remove a lot of tooth restructure. The line you see are the delimitation of the natural dentition position and the proposed one. They show you where and how much you need pre-prepare the tooth out. In this video, you can see where I pre-prepare the real teeth out. This step turned out to be simpler because everything had been planned digitally. After this, we have scanned his intraoral area again and sent into the lab. The top photos on the left-hand side show us that there are still some areas that need to be prepared out. The top mid-section photos show us that the fossa palatal of anterior teeth also need prepare out. You can visualize this area in the dark spots. We prepare out on the patient mouth and rescan his intraoral. The bottom photo on the left-hand side shows us the new scan with the proposal. We reapplied virtually the initial proposal on the new scan to make sure that there are not any more teeth surface that needs writing out or preparing out. The bottom mid-section photos show us the upper and lower arch, so we know all the dentition is correct positioned. The correction is done by the virtually articulator. This video shows the last mock-up applied into the patient's mouth. We scan the prepared teeth. Photos of the scanning of the prepared teeth. I also had the conventional silicone final impression done after the scanning for two reasons. First, because the technician who was going to do the finishing job, Rafael Ferro, doesn't like working with 3D resin printed models. He still likes to work with a cast model. The second reason is that cast models are more commonly used on physical articulator. These are photos of the cast model assembled in the physical articulator. Emerson has milled all the restoration. He placed it on the cast model assembled on the articulator, and Rafael Ferro will start the finishing process. Here are the final restoration and after Rafael finished the job. This photo shows the final restoration already applied into the patient's mouth. This is only proposal is exactly the same as the final restoration. This also shows you that the initial morphology proposed exactly the same at the final restoration. Do you remember the patient before photo? This is it. And here is the after photos. Now both before and after photos side by side. More after photos. The close photos on the final restoration already cemented into the patient's mouth. Final, the final photos with another kind of photos with flash. Thank you so much for watching. Thank you again to João Borges and Rui Pereira da Costa for this opportunity and organizing this great and revolutionary event. I hope to meet you around protocol, then that you will apply more and more in your daily practice. Thank you.